Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com. Young couples today are waiting longer than their parents did before they start having families. Will that make it harder for them to get pregnant? This is the People's Pharmacy with Joe and Terry Graydon.
Financial concerns and career challenges over the past several years have conspired to discourage couples from starting families. Once they reach their 40s and feel more secure, will they have a harder time conceiving?
What are the causes of infertility and what can be done to overcome it? For decades, the focus was on women, but men should also be included in infertility workups. Does it make a difference if men wear boxers or briefs?
Coming up on the People's Pharmacy, Dr. Mark Fritz answers your questions about overcoming infertility.
First, this news.
In the People's Pharmacy health headlines, new research from Sweden suggests a link between cold sores and Alzheimer's disease. In two separate studies, researchers examined blood for antibodies to the herpes simplex 1 virus that causes cold sores. In the first one, they studied almost 3,500 older people for 11 years. Those who showed evidence of reactivated herpes virus infections were about twice as likely to develop Alzheimer's as those who did not. In a second study, 360 people with Alzheimer's disease were matched for age and sex to people without dementia. Then the scientists studied blood that these people had donated years earlier. Again, antibodies to herpes were associated with double the likelihood of Alzheimer's disease. It's tempting to consider the possibility that treating herpes infections with antiviral drugs might lower the chance of Alzheimer's disease later on. But long-term, randomized, controlled trials will be needed to determine whether this will be helpful.
A recent study offers one possible way to keep cognitive function strong. In a study partially funded by the Mars Candy Company, 37 people between 50 and 69 were provided with diets that differed greatly in the amount of flavanols. They were randomly assigned to consume 900 milligrams of flavanols from cocoa or just 10 milligrams from cocoa daily. Brain scans and cognitive testing after 3 months determined that people performed better at the high levels of flavanols. Mars created a special high flavanol drink just for the study that's not available commercially, and nutritionists warn that flavanol levels in chocolate bars are not high enough to be helpful. Berries and tea may offer other sources of flavanol compounds that are similar, though not identical.
A widespread recall has been issued for baby wipes manufactured by New Tech Disposables. The company issued voluntary recall after discovering that some samples were contaminated with bacteria. Although the bacteria are not believed to pose a risk for healthy people, they could cause trouble for those with reduced immunity. The wipes were distributed in chains including Family Dollar, Sam's Club, and Walgreens, and may be returned for a refund. There's more information on the recall at the FDA's website.
A Mediterranean diet rich in vegetables, fruit, legumes, olive oil, and fish seems to keep kidneys healthy. A community-based study examined the diets of 900 volunteers who were followed for almost 7 years. Those whose eating patterns most closely resembled a Mediterranean diet were 50% less likely to develop chronic kidney disease. One of the most challenging aspects of the diet for many Americans is to forego desserts, except on very rare occasions.
A high-fat, low-carb diet, also known as a ketogenic diet, has been shown to be helpful in controlling seizures in children with epilepsy. A new study published in the journal Neurology suggests that adults with hard-to-manage seizures may also get some benefit from such a diet. The scientists reviewed 10 studies of diets rich in cream, eggs, butter, bacon, leafy green vegetables, and fish. About one-third of the subjects with epilepsy had 50% fewer seizures on a ketogenic diet. A small number had a remarkable response, with a 90% or better reduction in seizures. The diets can be challenging, in part because they defy conventional wisdom about a healthy diet.
Moderate alcohol consumption appears to offer brain benefits to older Americans. In a study of 660 people who filled out questionnaires on alcohol consumption and underwent MRI brain scans, investigators found that those who consume between 1 and 6 drinks a week perform better on memory tests. Too much alcohol is problematic. Those who consume 3 or more drinks daily were more likely to have cognitive impairment. Moderation seems to be the key.
We've long been told that milk builds strong bones, but a new study from Sweden did not show a link between high milk consumption and low risk of fracture. If anything, women who drank more than 3 glasses of milk a day were more likely to die in the 20-year follow-up. Fermented milk products, such as yogurt or cheese, however, were associated with lower rates of deaths or fracture. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Today we're talking about human reproduction, all the many factors that go into it, what can go wrong, and how it can be made right. When a couple decides that it's time to start a family, they may assume that this will happen more or less automatically once they stop trying to avoid pregnancy. Sometimes it does, but not always.
To find out how to overcome problems with fertility and set the stage for a good outcome, we turn to Dr. Mark Fritz. He's the Charles Hendricks Distinguished Professor of Obstetrics and Gynecology and Chief of the Division of Reproductive Endocrinology and Infertility at the University of North Carolina at Chapel Hill. He wrote the book on infertility. The textbook that he co-authored, Clinical Gynecologic Endocrinology and Infertility, is the most widely read in its field. He's a former president of the Society for Reproductive Endocrinology and Infertility. Welcome to the People's Pharmacy, Dr. Fritz.
Thank you. It's good to be with you.
Nice to have you here. And if you have a question about infertility, we invite you to give us a call. The number 888-472-3366. You can email us radio@peoplespharmacy.com or contact us via Twitter @peoplespharmacy. The number again, if you have a call, a question, a comment for Dr. Fritz, 888-472-3366.
Dr. Fritz, when a couple says, all right, it's time, we do want to start a family, what should they do, ideally?
Well, it might be good to start by visiting their primary care physician for a general overall health survey to understand any underlying illnesses that they may have, medications that they're taking for them, to gain a better understanding of how those medical conditions might affect their ability to conceive or how pregnancy might affect those illnesses, to begin treatment with a prenatal vitamin, a careful survey of any medications they are taking to make sure they're safe for pregnancy. Other than that, there really isn't more preparation required.
But I wonder about lifestyle, Dr. Fritz, because, it seems like if ever there were a good time to stop smoking, it seems like it would be around the time you want to get pregnant. And maybe if you're a woman, and perhaps even for a man, cut back on the alcohol. Am I making that up, or does that make sense?
No, not at all. There's very good evidence that tobacco use decreases fertility in women, and also evidence that it speeds the rate of decline in fertility that occurs naturally with age. So smoking is certainly detrimental to reproductive efficiency, and you're exactly correct that there's no better time to stop smoking than when you're planning a family.
And what about alcohol?
Alcohol in excess, and how that might be defined, is generally considered to be more than 2 alcoholic beverages daily. There is some evidence to indicate that that probably is best avoided. Less than 2 alcoholic beverages daily does not appear to have any adverse effect on fertility, and there's no reason to deny yourself that glass of wine with dinner.
Dr. Fritz, we've got an oddball question for you. So if you're ready, I'm going to throw you a curveball. There's been a big debate about boxers versus briefs, and we're going to ask you about that in just a second. But right now, I'm going to read you a question that we got from a visitor to our website. This fellow wrote, I've been wearing pantyhose every day for a while now to eliminate leg fatigue and help with varicose veins. I stand all day long at work in a restaurant, and I find the hose are great. And he tells us exactly what type and what size, but I don't think we need to get into that. And he says that his wife, his family, and his doctor all approve. So here's the question. We told him that we thought support pantyhose are just fine, unless maybe he's trying to start a family. If he and his wife are trying to get her pregnant, would pantyhose be a problem?
I wouldn't think so, no. Although heat is certainly a known reproductive toxicant, and in certain circumstances, in extremes or excess, can adversely affect male reproductive function. Questions like that are probably most easily addressed by simply taking an evaluation of the semen sample. And if it's completely normal, and there's no evidence to suggest that anyone need to change their lifestyle choices, then why should they be imposed?
And the boxer versus brief debate, has that been kind of blown up?
Largely so, yes, Joe. Again, boxers versus briefs, whereas the tighter fitting underclothing might increase the temperature around the testes, and heat does affect reproductive function. There's really very little evidence that a personal preference in underclothing is going to adversely affect your fertility.
Do you have a question for Dr. Fritz? Our lines are open. Have you had trouble getting pregnant? What was that like? Our lines are open at 888-472-3366 or via email radio@peoplespharmacy.com.
Dr. Fritz, we hear about the fertile period, and we understand that of course, is the best time for a couple to have relations if they're trying to conceive. Is this something that people can do at home? Is there a way to help them find that fertile period? Thermometers, iPhone apps, anything like that?
There are various methods that can be used with relative ease. Virtually all pregnancies result from sexual activity occurring within the 6-day interval, ending on the day of ovulation or egg release. And that interval can be predicted or defined in a number of ways. Generally speaking, ovulation is going to be occurring approximately 2 weeks before the onset of a normal monthly menstrual period. By subtracting 14 days or so from the normal intermenstrual interval, you arrive at the approximate time of ovulation, and by subtracting from that 5 to 6 days, you define pretty well the opening of that fertile window. But I would want to emphasize that an excess attention to specific fertile timing is really not necessarily at all a good thing. Many people take that a bit too far and have the view that if they abstain for long periods of time and focus their attention solely during the fertile interval, that they'll increase their fertility. But in fact, anything that reduces exposure, reduces opportunity, and reduces reproductive efficiency.
Well, that was exactly the question I have, because we did have an email question about restricting sexual activity to just the fertile period. So you're saying that's sort of a misconception?
No, we try very hard to not impose on people's intimate lives without good cause. And the optimum coital frequency, or the frequency of intercourse that appears to maintain best semen parameters or sperm quality, is approximately every other day. So if a couple is normally sexually active on an average of 2 to 3 times per week, they really need not spend a whole lot of time trying to figure out the fertile interval because they will inevitably be
They'll
active
hit it
within
somehow.
it. That's correct.
888-472-3366 is the number to call if you'd like to join our conversation. We go to Tampa, Florida. Mike, you have a question for Dr. Fritz.
Yeah. Hi, Joe and Terry. I was just curious. I understand, daily alcohol use, like you were just saying, and smoking tobacco can be definite deterrents or however you would put it to reproductive health. What about daily marijuana use over a long period of time?
I would have to say that marijuana use is, in general, best discouraged. There is some evidence that use of recreational drugs, including marijuana, particularly on a regular and frequent basis, can adversely affect reproductive function, sexual desire, and overall reproductive efficiency.
Sorry about that, Mike.
Right.
Bye-bye.
Right.
When should a couple start getting nervous, Dr. Fritz? In other words, the decision has been made, let's have a family. Let's start the process. At 2 months, 6 months, a year? When should a couple start thinking about consulting an infertility specialist such as yourself?
Well, for the normal, young, healthy couple, presumed fertile, they can reasonably expect, in the absence of any fertility factors, that they can conceive with about 85% efficiency over an interval of 9 to 12 months. The majority of pregnancies that occur in normally fertile couples are going to be seen within the first 3 to 6 months after they begin an active effort. If they have been reasonably regularly sexually active for a period of approximately a year or more, then that increases the probability that there may indeed be an obstacle that would best be defined and overcome.
So somewhere between 6 months and a year and a half, it's time to make an appointment. With whom should they make that appointment?
Well, most people can begin any diagnostic evaluation or investigation of their fertility or concerns about their inability to conceive with their primary care physician or their general obstetrician gynecologist. Things as simple as looking at menstrual cycle regularity and frequency can easily identify one of the more common and treatable causes of infertility, which is problems with ovulation. And those are easily managed and generally very effectively treated by one's primary care physician or general gynecologist. If they cannot identify causes for infertility through normal diagnostic evaluations, or when that evaluation is completed and reveals obstacles that can't be overcome by simple measures, then consultation with a reproductive specialist is probably prudent.
Okay. Well, we're going to be taking a short break, but we want you to start thinking about men because, for decades, women got all the attention. If a couple couldn't get pregnant, it was always something wrong with the woman. But now we're starting to pay a little more attention to men, and we're going to find out how and why. When we come back, we're going to talk about how problems can be diagnosed and treated in both men and women. If you've got a question about fertility, infertility, or anything related to such a question, give us a call. 888-472-3366. Email us, radio@peoplespharmacy.com, or via Twitter, @peoplespharmacy.
You're listening to the People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to the People's Pharmacy, you may also enjoy our book published by National Geographic. It's the People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible by Redx Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-2334. It's show number 968, or find it online at peoplespharmacy.com.
Today, we're talking about fertility and infertility. Back in the 1700s, when the first census was done, the birth rate was much higher than it is today. But if a couple had trouble, there was very little that could be done.
Our guest in the studio is Dr. Mark Fritz, the Charles Hendricks Distinguished Professor of Obstetrics and Gynecology and Chief of the Division of Reproductive Endocrinology and Infertility at the University of North Carolina at Chapel Hill. His textbook, Clinical Gynecologic Endocrinology and Infertility, is a classic. He's a former president of the Society for Reproductive Endocrinology and Infertility.
If you have a question for one of the most respected infertility experts in the world, this is your chance. Give us a call at 888-472-3366. You can also send us an email where it's radio@peoplespharmacy.com, or reach us by way of Twitter. We're at People's Pharmacy.
Dr. Fritz, the most common problems that interfere with fertility, both for women as well as for men?
Well, there are probably four main causes for reproductive failure in most couples, and in no particular order or priority. Those would be problems with ovulation, abnormalities of female reproductive anatomy, meaning abnormalities of the uterus or fallopian tubes, then abnormalities of semen quality or male factors, and then reproductive aging.
How do you go about diagnosing the problem? I mean, obviously you can get a semen sample. That's pretty straightforward. What about with ovulation or anatomy?
Well, there are a number of ways to evaluate ovulatory function. A regular, normal monthly period that occurs at consistent intervals and is associated with consistent menstrual flow characteristics and ushered in by a consistent pattern of recognizable symptoms, all strongly imply ovulatory function. With very few exceptions, that will be true. If it's necessary to confirm or corroborate that suspicion, then there are objective measures of ovulatory function that can be employed. One simple way would be to measure the blood progesterone level, which is one of the two major female hormones and the one that's released in significant quantities only after ovulation has occurred. So a blood sample that's obtained approximately a week before the expected period for the hormone progesterone can easily determine whether ovulation has recently occurred. It doesn't tell you how well or precisely when, but it will tell you yes it did or no it didn't. The couple themselves could use an ovulation predictor kit, these over-the-counter products that are now pretty effective and efficient in detecting the hormonal trigger, so-called LH surge, that stimulates actual egg release just before ovulation. And these over-the-counter urinary test kits can detect that signal. The best among them will predict physical ovulation occurring within the next 24 to 48 hours with better than 90% efficiency.
So these are actually a worthwhile purchase.
They are for couples for whom defining the precise time of ovulation and the optimum time for sexual activity is important. But again, I want to stress that it's not necessary to employ such measures for most couples. Mm-hmm. But if a couple has relatively infrequent intercourse or diminished opportunity because of travel schedules and workloads, then it might make sense for them to try to better define the interval of time during which sexual activity is most likely to be successful.
What would go into a workup then? after you have determined that ovulation is normal, where do you go next in the infertility workup?
Well, any general infertility evaluation should include at least a basic assessment of the male. Contrary to popular belief in the past, male factors are a really very common cause, or at least a contributing factor, in infertility in many couples. Most estimates would place male factors as important in the reproductive failure of many couples in approximately a third. They could be and often are, the sole cause, and often are also a contributing cause. So a simple semen analysis can make an assessment of semen quality. There's 3 major parameters that come from that test that have some predictive value. Sperm count or concentration being 1, motility, describing the proportion of the sperm population having purposeful forward motion, and sperm morphology or shape, which is our best available current predictor of what we'd most like to know, which is, do they work? Can the sperm actually attach to, penetrate, and fertilize an egg? We do not have an effective test for that important part of the reproductive process, but this is the best surrogate marker.
Go ahead.
What can we do in the case of ovulation problems? So if a woman is not ovulating regularly, do we have drugs to help? And then in the event that it is a sperm problem, are there ways to overcome that?
There are a number of medications that can be used to improve or to induce ovulation in women who don't ovulate at all or do so infrequently or poorly. The most common medications are orally active agents. The 2 most commonly used are called clomiphene citrate and more recently a medication known as letrozole. The trade name for the first is Clomid and the second Femara, which may be more familiar to some of the listeners. These medications act similarly but also differently. They, in the case of clomiphene, look to the body like estrogen, and they compete with estrogen for the little parking places or receptors throughout the body where estrogen goes. But in the case of treatment, the medication always wins that competition because we cheat. We administer the medications to achieve concentrations in the blood that are far in excess of those of estrogen itself. So at the level of the brain, the medication occupies those receptors, makes the brain believe that estrogen levels are really lower than they are, hoping to trigger a compensatory increase in the level of stimulation to the ovaries in the form of follicle-stimulating hormone that comes from the pituitary gland.
We've got a couple of questions from listeners who have emailed us that relate to the male factor. So Angela wants to know, can exposure to Agent Orange cause infertility in men? And she goes on, my husband was deployed to Vietnam as an outdoor road construction worker and was exposed to Agent Orange spraying for 18 months. Since his return, he's unable to have children even though all his siblings have had children. So, do we know anything about Agent Orange and its effect on sperm quality?
Well, I don't specifically, although Agent Orange and other similar herbicides and pesticides are among the organic pollutants in our environment. And for those individuals who were exposed to some of those more potent agents during wartime or in other capacities, certainly there would be at least the potential for adverse effects. But the easiest way to determine whether that may be true, again, would be to assess semen quality and to determine whether or not there's anything to be concerned about.
888-472-3366 is the number to call if you have a question for Dr. Fritz. You can email us, radio@peoplespharmacy.com, or via Twitter @peoplespharmacy. That number again, if you have a question about fertility or infertility, 888-472-3366.
One more email related to the male factor, which comes in from Michael. He says, does carrying a cell phone near the genitalia, carrying a cell phone down low, does that affect fertility?
I don't think there's any credible evidence that that's true.
Okay.
Now, let's just say that you do the sperm analysis and you discover there aren't quite enough. It's a little low. Sperm count is low, or maybe motility is not as great as it should be. What can be done?
Well, we are not nearly as well informed about the factors that adversely affect male reproductive function as we are about the female, and so we have more limited methods for overcoming that obstacle. Certainly a urological evaluation is reasonable to exclude anatomical abnormalities in the male, such as obstructions or more important abnormalities of the testes themselves. Drugs and medications can adversely affect fertility in men, and we want to exclude those factors. There are some correctable causes of decreased semen quality, such as obstructions and endocrine or hormonal abnormalities. But a large proportion of male infertility is largely unknown. And then if we can't identify the cause and specifically treat it, then we have to find a way around it or over it. And our two best tools in that regard are, first, artificial insemination, a method where we can take a semen sample, concentrate the sperm from it, and then deposit that concentrated sperm sample directly into the partner's uterus through the cervix in a relatively simple office procedure. That works well for mild seminal abnormalities, but more severe abnormalities with severe decreases in sperm concentration or motility may then require assisted reproductive technologies to overcome them.
Can we switch gears and talk a little bit about hormones? You mentioned maybe low testosterone might have some effect. I'm curious if that's truly the case. We see a lot of commercials on television for low T these days, not just presumably for fertility reasons, but for all kinds of reasons. What about thyroid? So first, the T of testosterone, and then the T for thyroid.
Well, normal sperm production in the testes certainly does require normal amounts of testosterone. The area in the testicles that produces sperm, in fact, concentrates testosterone to much higher levels than are in blood. Low serum testosterone levels can not only decrease the level of sexual interest, but can also be associated with poorer sperm production. Unfortunately, if men choose to treat themselves or to receive treatment with extra testosterone, which may improve their sense of well-being or vigor in some ways, that very commonly adversely affects sperm production because the endocrine system in men is very similar to that in women. The brain will monitor the level of testosterone in the blood. If it's happy with what it is, then it will maintain a maintenance level of stimulation to the testes. But if it sees excessive or high levels of testosterone, then it will deduce that it needs to stimulate the testicles less. And that reflex response will then diminish stimulation to the testicle and frequently results in decreased sperm concentration or production.
Sort of paradoxical. What about thyroid?
Yeah, we're interested in thyroid. I'm assuming that could affect either men or women, but certainly we have a lot of information about thyroid and its impact on women's fertility. You've got a nice thick chapter in your book about it.
Well, thyroid hormone is a very important hormone for almost all normal bodily functions, and certainly reproductive function is among them. Thyroid disease and disorders are much more common in women than they are in men, but certainly can be seen in both. It is a standard part of any evaluation of an infertile female, particularly those who have menstrual dysfunction, since thyroid abnormalities are one cause of that and one that is easily managed or effectively treated. Thyroid disorders are generally easily enough managed or treated with extra thyroid hormone for the most common hypothyroidism. that evaluation of thyroid function makes sense in anyone experiencing reproductive failure because it's so easily identified and generally so easily corrected.
And it makes a difference.
It does.
Now, Dr. Fritz, when you say menstrual dysfunction, I'm hoping that you'll give us a little more detail because, quite honestly, having had a thyroid problem myself, as a younger woman, I would not have identified the menstrual difficulty as the symptom that tipped me off to a thyroid problem. But in fact, that was one of the symptoms that alerted the doctor to it.
Well, menstrual dysfunction would be basically a deviation from the normally expected pattern of regular periods that generally should occur no more often than about every 25 days and no less often than about every 35 days. Normally, fertile women will typically have a regular and predictable menstrual period within that interval of time. Abnormal patterns of bleeding, variable patterns of flow, variations in the interval between periods, these are all subtle, sometimes more obvious symptoms that something is awry, and thyroid abnormalities are one of the causes that would need to be excluded.
And as you say, this is easily treated. The appropriate level of thyroid hormone should get things back on track.
Generally so, yes, if that is an important causative factor.
Okay. And when it comes to men, I'm assuming that for the most part, once you've done the analysis, as you've suggested, and tried to concentrate the sperm and done the appropriate extraction process and implantation process, how effective is that?
Well, it depends in part, Joe, on what we're using insemination for or what obstacle we're trying to overcome. The two most common places we would apply that strategy would be in couples with relatively mild but important contributing male factors in an effort to deliver more actively motile sperm in the immediate vicinity of the egg that is soon to be ovulated. The other setting where we employ it is in the treatment of couples with unexplained infertility, where the purpose of the insemination is to deliver more than the usual numbers of sperm, most of the time in combination with treatment of the female partner to purposely try and cause ovulation of more than one egg to bring together more than the usual numbers of eggs and sperm and thereby to increase reproductive efficiency.
We're going to take a short break, but when we come back, we're going to dig really deeply into your specialty, and that would be, well, what are the other strategies, the high-tech approach, in vitro fertilization? How does it work? How good is it? Are there any dangers? And if you'd like to join the conversation, the number 888-472-3366.
Exactly.
And by email?
By email, we're radio@peoplespharmacy.com. By Twitter, @peoplespharmacy. You're listening to the People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to the People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth creams and lotions, helping dry, cracked feet feel utterly soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
Our guest today is Dr. Mark Fritz, the Charles Hendricks Distinguished Professor of Obstetrics and Gynecology and Chief of the Division of Reproductive Endocrinology and Infertility at the University of North Carolina at Chapel Hill. He's author of one of the most widely read textbooks in the field. It's called Clinical Gynecologic Endocrinology and Infertility. He's former president of the Society for Reproductive Endocrinology and Infertility.
If you have a question about infertility or a story to share, our lines are open. You can reach us at 888-472-3366. You can send an email to radio@peoplespharmacy.com or you can send us a tweet. We're at People's Pharmacy.
That number again, 888-472-3366. We go to Dallas, Fort Worth, Texas. Rich, what's your question, please, for Dr. Fritz?
Hi, Joe and Terry. I was curious, after an insemination, how long do the sperm remain active or alive that a pregnancy can occur? Thank you.
Oh, it's a good question. Sperm can live within the female reproductive tract for quite some time when put there by way of natural intercourse. I mentioned earlier that fertility can result from intercourse occurring anytime within the 6 days preceding ovulation, although the likelihood increases as the proximity to ovulation gets closer. After insemination, though, the sperm that are washed and put directly into the uterus, best evidence suggests that they live a lot less long, and that's why the insemination should be as carefully timed to coincide with the time of ovulation as possible, because once released, the egg is only fertilizable for approximately 24 hours.
We go to Susan in Raleigh, North Carolina. Susan, your question, please.
Hi there. I absolutely love your show. Listen to it almost every Saturday, and my question, I have two questions. At what point during ovulation for women who experience cramps is fertility, like where do cramps and fertility during ovulation relate?
Well, most women do not have any recognizable or consistent pattern of ovulatory symptoms. Some do, so-called Mittelschmerz or ovulatory pain. But the proximity of that symptom to the actual time of egg release, I don't think is very easy to define, and I wouldn't know that I would necessarily rely upon that to optimize the timing of intercourse.
All right, let's go to Liz is not quite ready, but we're almost going to take Liz's question because it has to do with something we're very interested in.
Well, we also have an email question. Dr. Fritz, you mentioned that reproductive aging is one potential cause of infertility, and we've got a question from a gentleman who would prefer not to be identified. He says, I'm 79. What's the likelihood of impregnating my female partner?
Still possible, but significantly lower than in the past.
Now, are there problems for older fathers? Are they more likely to father a child with, for example, autism or Down syndrome or something like that?
There is evidence to support that notion. There is an increase in the incidence of certain types of genetic abnormalities in children conceived by fathers in excess of age 50. Although fertility declines with age in both men and women much more dramatically and appreciably in women than in men. In men, aging doesn't typically have an adverse measurable effect on fertility much before the age of 50, but thereafter certainly can.
You know, that does bring up the question, at what age is it optimal? My mother was 40 when I was born. So obviously women can become pregnant in their 40s. But what's best?
Well, female reproductive efficiency peaks in the young, typically between the ages of 20 and about 32, and then begins to gradually but measurably decline with time. And the rate of decline isn't linear. It doesn't slowly go down. In fact, it picks up speed as it goes forward. So fertility, once it begins to decline, will increase in the speed with which it decreases. So fertility is importantly reduced in women over the age of 35, again at the average age of about 37 or 38, and much more substantially after 40. for the most part, after age 42, fertility is dramatically reduced.
And we go to Liz in, I'm not sure where you are, but Iowa?
Yes. Good morning, Joanne and Terry.
Now, Liz, where are you in Iowa?
Dubuque, Iowa?
How great.
Okay, Dubuque. Well, what is your question, please? Because we had been hoping to ask Dr. Fritz a question about this very condition.
Oh, well, wonderful, yes. My daughter, at about 15 years old, about a year after she started her menstrual cycle, stopped having one. And it has been discovered that she has PCOS and has been on birth control ever since to force her to have a period. And I'm just wondering, how difficult will it be someday for her to have a child?
Well, thank you, Liz, for that question. Polycystic ovary syndrome is the most common hormonal abnormality in women across the world. Depending upon how one defines it, may affect even as much as 10% of women. Its two primary symptoms are menstrual irregularity, generally menstrual infrequency, and very often also gradually increasing evidence of excess male hormone production, usually resulting in the growth of unwanted hair on the face, chin, chest, or lower abdomen. The loss of menstrual periods or the decrease in frequency of menstrual periods is simply a symptom of the most common abnormality observed in women with polycystic ovary syndrome, and that is ovulatory dysfunction. Again, the thing that gives periods regularity is ovulation, and infrequent menstrual periods are clear evidence of decreased ovulatory frequency. So if ovulation is occurring less often, maybe not even at all, then indeed there's reason to anticipate that there may be problems with reproductive efficiency later when your daughter's ready to begin a family. Generally speaking, though, those can be overcome without undue difficulty if that's the only obstacle.
So how is PCOS then treated to overcome the infertility problems that it poses?
Well, in women who aren't interested in conceiving, you're trying to help restore regular menstrual periods and to prevent or treat the abnormal hair growth that may result from the high levels of male hormone production. But in women with that disorder who want to conceive, the treatment is, of course, to try and restore ovulatory function using first the orally active medicines that I mentioned a bit ago, and should they fail, as they may in about 1 in 5 such women, then more potent injectable fertility medicines may be required.
Dr. Fritz, a few minutes ago we were talking about reproductive aging, and it occurred to me that, as you mentioned, women are at their peak between, say, 20 and 32. There are now some young women who are, say, perhaps in their 30s, who haven't yet found a partner, who do eventually want to have a family. They're thinking about freezing their eggs. Is this at all indicated? Is it recommended? Can you tell us a little bit about it?
Well, certainly it's been in the news a lot since a couple of companies have made a large public statement about their healthcare insurance coverage for their employees now covering elective egg freezing. Until relatively recently, that was not feasible to do. The egg is the largest cell in the body and has a high water content, and water and freezing don't mix too well usually. Form ice, and ice inside of a cell doesn't do too much to maintain its integrity and its reproductive potential. But we've largely overcome those obstacles now by ways of removing water from the eggs and then freezing them very rapidly before ice crystals can actually form. So elective egg cryopreservation or freezing is now no longer considered investigational. It is established medical care. But one of the biggest controversies in our field right now is who should pursue elective egg freezing, and if so, when. Most of us would agree that it's probably not appropriate for very young women at the beginning of their reproductive life, and most of us would probably also agree that it makes little sense for women at the very end of their reproductive life. The factors that will determine whether one should seriously consider it depends on the size of the family they hope to have, the likelihood or the prospects for partnering in the near term, the presence or absence of other already known fertility factors, and the importance to them of ultimately achieving that goal of having their own biological child.
Let's talk now about your specialty, which is IVF, in vitro fertilization. What is it? How good is it? And are there any risks?
Well, in vitro fertilization, if we just take that term apart, simply means fertilizing the egg with sperm outside of the body, or in vitro, with in vivo meaning inside the body. The parts of IVF basically are these. First, we stimulate the female partner with potent injectable fertility medicines, which really aren't anything special. They're simply purified concentrates of the hormone, follicle-stimulating hormone, that the body itself makes and would normally stimulate the ovary. We just administer them in purposeful excess, so to keep a larger proportion of the follicles containing the eggs that would normally be developing in any one cycle, all growing together, instead of allowing that number to dwindle down to the normal release of a single egg. That interval of stimulation typically lasts about 8 to 12 days. At the peak of the maturity of the most advanced follicles, we administer a trigger shot of a medicine that takes the place of the normal ovulatory trigger. And then about 36 hours later, the patient returns to the office and, generally under intravenous sedation, undergoes an egg retrieval procedure, which involves the introduction of a needle through the top of the vagina under the guidance of imaging obtained by ultrasound, directing that needle into each of the follicles inside the ovary containing the eggs, removing those fluids, first one ovary, then the other, and then in the laboratory, typically adjacent to the procedure room, those eggs are isolated from the fluid and later that day fertilized in vitro with the sperm of the partner. Fertilization can occur by one of two ways. Conventional fertilization methods would be just mixing the sperm with the eggs in the little petri dish. And when necessary, we can actually isolate individual sperm and physically insert one each into each mature egg to achieve fertilization in vitro. The next day, we get to find out how many of those eggs fertilized, and the average is about 2/3 to 3/4. And then over the next 3 to 5 days, the embryos are maintained in the incubator in the laboratory, where they progressively develop, first dividing into 2 cells, then 4, then 6 to 8, and then ultimately arriving at a stage called blastocyst, which is the stage of development where the embryo begins to separate into the portion that will be the embryo itself and the portion that will be placenta. That's the stage of embryo development where an embryo would normally arrive in the uterus through natural fertility. And at that point in time, ideally, is when we select the best among the available embryos and insert it directly into the uterus through the cervix.
And how effective? I mean, how many pregnancies result as a result of this IVF process?
Well, a great many more now than in the past. This technology has matured greatly and has seen a number of important advances over time. In present day, on average, the probability for success with in vitro fertilization, of course, does relate primarily to the age of the female partner. But across the United States, the average would be about 45% per try for women under 35, about 35% per try for those 35 to 37, about 25% per try for those 38 to 40, and about 15 to 17% for those over the age of 40.
And is there any way to increase the likelihood of implantation?
Well, one of the ways that we try to overcome that inefficiency is by putting back into the uterus more than one embryo, trying to compensate for the higher probability that a given embryo at a certain age will in fact have true developmental potential. But of course, there's no real way to know that for certain. On at the time that you make the decision of which embryos to put into the uterus. So it's still, we put back fewer embryos in younger women, typically one if we can, and increase that number as age increases to try to improve reproductive efficiency.
Well, speaking of age, we have Jeff. He's driving in New Mexico. He's a trucker. Jeff, welcome to the People's Pharmacy. You have a question about age issues?
Yeah, I'm 48, and my girlfriend's 39.
I'm sorry, we missed that. You are how old?
I'm 48.
48, and your girlfriend is?
And she's 39.
And the question?
And we've been trying to have a child for the last year, and it kind of seems like nothing's working. What kind of advice can you give us to conceive?
Well, given that your partner is 39 years of age and now in her late reproductive years, my best advice I could give you now, I think, would be to, at your earliest opportunity or convenience, seek a consultation with a reproductive specialist so that an evaluation for any factors that might be interfering with your ability to conceive can be quickly identified, so that time and attention can be turned to methods of overcoming that or treating you to help you to conceive. But it's certainly time for you to undertake a thorough evaluation.
Dr. Fritz, we're nearly out of time. Very briefly, what questions should a couple ask the doctor as they face fertility problems?
Well, I think that most couples are going to want to know, and typically do want to know, can they be optimistic about their chances to conceive once they've had difficulty and are now beginning evaluation? And the answer to that is, in most cases, indeed so. There's every reason for cautious optimism in most couples who aren't already well beyond a normal reproductive age. We should reassure them that the evaluation of infertility can generally be completed within a very short time, typically within the span of a single menstrual cycle, and that we can look forward to turning our attention to methods for overcoming any identified obstacles, and even for treatment of those with unexplained infertility in whom we can't find the cause as quickly and as efficiently as possible.
And you've made extraordinary progress over the last couple of decades.
Well, certainly we have more tools and better tools now than we did in the past. We used to rely more on things like reproductive surgery, but for quite some time now, assisted reproductive technologies have exceeded what could be achieved with those older methods, and that's much less common now.
Well, thank you so much for joining us, Dr. Fritz. Dr. Fritz is the Charles Hendricks Distinguished Professor of Obstetrics and Gynecology and Chief of the Division of Reproductive Endocrinology and Infertility at the University of North Carolina at Chapel Hill.
Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wadarsky engineers. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
And if you'd like to order a copy of today's show, it's number 968, the number 800-732-2334. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks very much for listening, and please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.